Assalamu alaikum and hello to the smart, amazing, talented, creative. Who wrote this script?
What? That's crazy. How did that get in there?
Anywho, welcome back to PodBites, everyone, where we break down complex medical topics into bite-sized pieces. Perfect for your commute, coffee break, or whenever curiosity calls. I'm Marwa Kaidali, also known as your embryo nose girl, as well as your host for today's episode, and I'm joined by Shahad Hammad, where we will be diving into a topic that affects many women, uterine disorders.
Hello, everyone. I'm Shahad, and I'm really excited to be here. As Marwa said, today we'll be diving deep into uterine corpus pathology. Sounds heavy, but trust me, we're going to keep it light and easy to follow. I can assure you, you'll be hearing our voices during the exam when you're stuck on that one anovulation question, or maybe during an endometrial hyperplasia SAQ. Not that I'm saying you'll get stuck on the exam. I mean, if you're listening to this, it means that you're serious about your prep, and you know what I mean.
Yeah, alright. Anyway, before we get into any diseases, let us rewind a bit. What does the normal endometrium even do?
Good question. It goes to the ultimate makeover every month. We kick things off with the menses, where the top layer of the endometrium, called the functionalis, just sheds away. It's a total demolition zone.
Right after, during the proliferative phase, estrogen shows up and says, alright, time to rebuild. And so the glands and stroma start growing rapidly.
That's right. Then here comes ovulation. Estrogen steps down, chills out, then progesterone takes over, and the endometrium starts getting all sorts of new features. You start seeing secretory vacuoles just beneath the nuclei. That's when you know it's prepping for a baby. By day 21 to 22, spiral arterioles appear. Then around days 24 to 28, neutrophils and lymphocytes come in, together with the predecidual changes.
Finally, if no embryo checks in, everything collapses. Spiral arteries constrict, you get bleeding into the stroma with breakdown of the functionalis layer, and the cycle restarts.
Now, sometimes this beautiful monthly rhythm hits a wrong note, and that's when we get abnormal uterine bleeding.
Exactly. But here's the catch. When we say dysfunctional uterine bleeding, that means there's no structural cause. No polyps, no fibroids, no tumors. It's just hormonal chaos, aka dysfunction.
And you know what the number one troublemaker is, Marwa? Anovulation. You know, the ovaries don't release an egg, so you get all of this unopposed estrogen telling the endometrium to grow and grow without progesterone hitting the brakes. It's crazy up in there.
You're right. This explains why teenagers and perimenopausal women, whose hormone levels are all over the place, are the most common victims.
One more thing before we move on. If you see postmenopausal bleeding, the time when you're not supposed to bleed, huge red flag. Always rule out cancer first. You don't want to miss that. All right, now, moving on. Picture this. A 55-year-old woman walks into the clinic. She's postmenopausal, obese, diabetic, and she's been having these weird episodes of heavy bleeding.
Let me guess. Her endometrium's been partying way too hard under estrogen's influence?
Exactly. She's got endometrial hyperplasia. What happens is the glands and stroma start to multiply like crazy, with the glandular part proliferating more, and the gland to stroma ratio gets totally out of hand.
Wait a second. The culprit is prolonged unopposed estrogen, right?
Right. Whether it's from anovulatory cycles, PCOS, granulosa cell tumors, cortical stromal hyperplasia, or even just popping estrogen pills without progesterone, any of these things can set it off.
And fun fact, one of the earliest genetic changes you'll see are the PTEN mutations.
Yes, PTEN loss opens the door to hyperplasia, and eventually cancer if things keep getting out of hand.
Who usually gets endometrial hyperplasia?
Milder forms usually hit younger women, and they often regress on their own or with a little help from progestins. But the scary form pops up mostly in peri and postmenopausal women and can seriously be a ticking time bomb for cancer. I can't stress this enough.
Oof, that's scary. Now, let's break it down. What types are there?
We use two categories for classification, either hyperplasia without atypia or atypical hyperplasia. A bit of a wordplay over there, but let me break it down. The first type, hyperplasia without atypia, generally behaves well because it doesn't have atypia. They regress with treatment or even spontaneously. Only 4.6% progress to adenocarcinoma in 20 years. On the other hand, atypical hyperplasia, aka endometrioid intraepithelial neoplasia, that's a mouthful, is not so friendly. 28% can progress to cancer, and 43% of cases already have a hidden carcinoma somewhere, and you need to look for it.
Okay, now that's really scary. How did it look under the microscope though?
So, in the type without atypia, glands are crowded but still look kind of normal. They have elongated pseudostratified cells that are mitotically active, no crazy nuclei, and there's increased endometrial tissue volume. But in the type with atypia, you get plump, irregular nuclei, big nucleoli, coarse chromatin, and sometimes even eosinophilic cytoplasm.
Wait, what about endometrial polyps? Are those related?
They're these little projections into the uterine cavity, usually small but sometimes big, and while most are harmless, they can also cause abnormal bleeding.
And occasionally, adenocarcinoma can sneak in there, right?
Yeah, but it's rare. Still, if a polyp looks weird, better to remove and check it. All right, listeners, next case. A young woman comes in with infertility, pelvic pain, some odd bleeding, and she had a miscarriage recently.
Sounds like it might be chronic endometritis.
Wow, okay, Einstein. That's right. Chronic endometritis happens when the endometrial stroma gets infiltrated by plasma cells. And the causes? Pretty much anything that irritates the uterus, like retained products of conception, IUDs, chronic pelvic inflammatory disease, and even TB in rare cases.
Do we need to take a biopsy?
Yeah, it's diagnosed by seeing plasma cells on biopsy because normally the endometrium doesn't have plasma cells. Unfortunately, though, it's very hard to diagnose. But if you do diagnose it, you could treat it with antibiotics.
Interesting. The culture can sometimes be negative though, right?
Yep. That's why we don't wait around for culture results and just give antibiotics right away. A sign not to procrastinate. Moving on. Imagine a 67-year-old postmenopausal woman and she's spotting blood.
Oh no, those are really big red flags. Probably endometrial carcinoma?
Absolutely. It's actually the most common invasive cancer of the female genital tract. And globally, it's the fifth most common cancer in women.
It's got two types, type 1 and type 2. Let's break it down. What's type 1 like?
Type 1, also called endometrioid carcinoma, is the most common, making up 80% of cases. It is usually tied to unopposed estrogen exposure, it's well differentiated, slow growing, and often comes from hyperplasia, although it may come independently.
What are the risk factors?
I'm glad you asked. Same factors with high estrogen, like we saw in hyperplasia, like obesity, diabetes, hypertension, late menopause, estrogen therapy, tamoxifen, nulliparity, PCOS, and this time, high socioeconomic status.
And what about the genetics?
There are many genes involved, but the one you should remember for endometrioid carcinoma is definitely the PTEN mutation.
So, type 1, called endometrioid carcinoma, is the most common and is due to too much estrogen. Now, what about type 2?
Type 2 is a serous carcinoma. It's a different beast altogether. It's bulky and aggressive, occurs in older women with atrophic endometrium, no estrogen connection, and most of them have TP53 mutations. Not to mention, extrauterine extension is pretty common as well.
Okay, so type 2 is the serous carcinoma. It's seen in older women with atrophic endometrium and most of the time has the TP53 mutation. You could say that serous carcinoma is pretty serious.
You just had to sneak that one in there, didn't you?
Now, how do these tumors look?
Grossly, the tumors can be polypoid, infiltrative, or totally normal looking. Microscopically, both are adenocarcinomas, but the serous type is way uglier with tons of cytologic atypia. Like you said, the serous type, it's pretty serious.
And how do they spread?
Via direct myometrial invasion, lymphatics, and in later stages, lungs, liver, bones, you name it.
So, what is the prognosis for such patients?
Type 1 usually does better. Type 2, not so much. The major determinant of survival is staging.
Ooh, and how do we stage exactly?
Get this. Stage 1 is confined to the uterus. Stage 2 has gone into the cervix. Stage 3 is outside the uterus but still in the pelvis. And finally, Stage 4 has gone beyond the pelvis or into the bladder or rectum. Okay, new patient now. A 38-year-old woman with heavy periods and a uterus that feels irregular and enlarged.
I know that one. Sounds like fibroids. Leiomyomas.
Yes, these are benign smooth muscle tumors, the most common neoplasms in women.
And they love estrogen too, right?
Love is an understatement. They grow during pregnancy with estrogen and oral contraceptives and shrink after menopause. Fun fact, around 70% of them have MED12 mutations.
What an interesting love story. And how exactly do they present?
They usually come in bulk, not singular fibroids, and may be entirely asymptomatic. However, they may cause abnormal bleeding, even leading to anemia. They may interfere with embryonal implantation, leading to infertility, and may have various other symptoms according to their location.
Can you tell us more about their location or territory?
All right, if they're submucosal or just beneath the endometrium, they cause bleeding. If they're intramural fibroids, aka within the myometrium, they cause heavy periods and mass effect. The last location is subserosal, and these are, well, beneath the serosa. Or they can even be pedunculated. These fibroids cause pressure symptoms like needing to pee all the time due to pressing on the bladder, and the pedunculated ones may even detach.
That's crazy. Is that where parasitic leiomyoma is?
Yep, pretty gnarly.
On gross examination, fibroids look like those classic whorled, firm, tan white balls, right?
Yes, and under the microscope, you see smooth muscle bundles with super uniform cells and barely any mitosis. However, rarely a smooth muscle tumor turns evil, and that's a leiomyosarcoma.
That's totally different from fibroids, though, right? Even if they sound similar, because sarcomas are malignant.
Exactly. Leiomyosarcomas are bulky, fleshy, and they invade the uterine wall. And microscopically, they have major nuclear atypia, high mitotic rates, and zonal necrosis.
That sounds like bad news for sure. I believe the prognosis is pretty poor, but they're rare. Leiomyosarcomas usually peak around 40 to 60 years of age, and some have the MED12 mutation.
You heard her, guys.
All right, we're almost done. Let's put it all together.
Okay, first up, abnormal uterine bleeding. When the normal menstrual cycle gets thrown off, you can have bleeding that's too heavy, too random, or just plain unpredictable.
And when there is no clear cause, we call it dysfunctional uterine bleeding. Most often, it's hormonal, and ovulation is the big culprit, especially around puberty and menopause.
Exactly. But remember, postmenopausal bleeding, that's a whole other story. That's a big red flag, and you should always think about cancer first.
Then we talked about endometrial hyperplasia. Basically, it's when the endometrium gets bombarded by too much estrogen without enough progesterone to go against it. Glands go crazy, crowding out the stroma.
And there are two types of endometrial hyperplasia. First is without atypia, which is usually harmless and has a low risk for cancer. The second is with atypia, which is super risky. About 28% will become cancer if left untreated.
PTEN mutation pops up a lot here too. It's one of the earliest steps in the march towards carcinoma.
Then we slid over to endometrial polyps. These are little bumps that stick into the uterine cavity. Most are harmless, but a few can get hyperplastic and very rarely can have cancer.
Next, chronic endometritis. If you find plasma cells in the endometrial stroma, you've nailed the diagnosis. It's due to retained products, IUDs, PID, basically anything that messes with the inside of the uterus.
Then we hit the big boss, endometrial carcinoma. There are two major types.
Type 1, the good guy, relatively speaking, is estrogen driven, linked to hyperplasia, and has mutations like PTEN. Patients tend to be younger, obese, and have lots of estrogen exposure.
And then there's type 2, the bad guy. Serous carcinoma, usually found in older women, no estrogen link, full of P53 mutations. It's aggressive and doesn't waste time invading or spreading.
Stage matters a ton in prognosis. The earlier it's caught, the better the outlook.
And after that, we lightened up a little with leiomyomas, aka fibroids. These benign smooth muscle tumors are estrogen responsive and super common. They can cause heavy bleeding, infertility, or no symptoms at all.
Fun fact, around 70% of fibroids have a MED12 mutation. And if you cut one open, they look like a beautiful whorled white ball.
Finally, we ended with leiomyosarcoma, the not so nice version. These are rare, malignant smooth muscle tumors, usually popping up in women aged 40 to 60.
They're bulky, fleshy, invade the myometrium aggressively, and microscopically, they show tons of nuclear atypia, mitotic figures, and necrosis.
And unfortunately, their prognosis is pretty poor.
And there we have it, a full tour of the uterine corpus pathologies. Nicely wrapped up. Okay, now do you know what time it is?
Quiz time! Starting with the first question. What mutation is common in both endometrial hyperplasia and type 1 carcinoma? The answer is loss of PTEN.
On to our next question. What's the histological hallmark in chronic endometritis? The answer is plasma cells in this trauma.
One final question for our listeners. Hopefully an easy one. No pressure. Which type of endometrial carcinoma is associated with estrogen excess? The answer is type 1 endometrioid carcinoma.
All right, everyone, that's a wrap on today's episode of PodBites. Thanks for joining us, Shahad.
This was fun. Thank you for having me.
And thank you all for listening. Until next time.
Spotting blood.
Oh boy.
Boy. Right?
Let me do that again.
You just had to sneak that one in there, didn't you?
I know, I'm just too good. Guys, I hated that so much.